Hi everyone. In this chapter, we will be discussing eating disorders. The three eating disorders that we will discuss in today's lecture include anorexia nervosa, bulimia nervosa, and binge eating disorder. Eating disorders as a mental health condition has sometimes a misconception that it's about their relationship with food. But it's actually the person's primary coping mechanism or a symbolism for something bigger than what we as the nurses are seeing. In addition, what makes it a mental health condition is that it has a certain degree of impact on the person's day-to-day life. Physical assessment for these individuals is going to be crucial. We might see imbalances of their nutrition, which might be reflective in their labs, such as their electrolytes or albumin levels, especially depending whether they starve themselves or if they're overeating. And for some, it might not be physically visible, but when you look at the labs, it might tell you a different story. We're also going to do our mental status assessment, and I go over this in a little more detail about each eating disorder in the next few slides. We also want to look at the patient's perception of their eating disorder. What does it mean for them to have this? And this can be a very complex question, but when we are taking care of them, seeing how they view their eating disorder, whether they idealize it or it's something that really drags them down, and they feel like they have no control over it, we're going to derive some of the goals or outcomes in their treatment based on how they see their eating disorder at that time. A lot of eating disorders depend on the severity, how severe their symptoms are at the time of which we are assessing them in their journey. Their psychosocial history. How does their environment, social circle, culture, religious beliefs, occupation, whether they're a student or have a job, how do those get impacted? Are there any positive or negative influences from these aspects of their life? How does their daily routine look like, maybe at home? Some individuals have their mind revolving around food almost all day, all night. Let's say maybe 90% of the time, and that's just an arbitrary number, that they're thinking about food and everything surrounding food. And when I say thinking about food, I'm not just saying, oh, what they're going to eat next or whatnot. It has everything to do with the preparation, the planning, who they're going to eat with, or when they're not going to eat with other people. They may rearrange all the other aspects of their life surrounding food and food-related situations. For comorbidities, there are other mental health conditions that predispose somebody in developing eating disorders or vice versa. These can be certain personality disorders like borderline personality disorder, anxiety and anxiety-related disorders such as obsessive-compulsive disorders, substance use disorders, and specific phobias. There are also medical conditions that either are a result of their eating disorder, such as cardiovascular-related conditions and electrolyte imbalances that could happen and actually could give rise to cardiovascular conditions in of itself. You could also see a lot of gastrointestinal, such as esophageal tears or esophagitis, and obesity for bulimia nervosa and binge eating disorder. So we're going to first look at anorexia nervosa. The DSM-5 TR characterizes this by restricted energy intake, sometimes as few as maybe 500, 600 calories a day. They'll usually have a BMI of 17 or less. They have an intense fear of gaining weight, and so will do anything and everything they can to avoid it. So there's two types of anorexia nervosa, and the first one is restricting, where they pretty much restrict themselves to the type of foods they eat. Some of them call them safe foods, and these are foods that they are allowed to eat, and everything else outside of it is bad. Or they can restrict themselves by calories, or restrict themselves by what times are okay to eat and not eat. The other type is binge eating, purging type. These individuals use compensatory behaviors to undo what they've eaten. These are things like self-induced vomiting, laxative or diuretic use, exercising frequently, maybe throughout the day or multiple times a day or multiple times a week for hours. There is an element of control between individuals and the behaviors of their disorder. Having certain personality traits such as perfectionism or a rigid mindset can make treatment challenging, and you might meet them, or they might meet you with a lot of resistance. Even if you were to show them pictures of how thin they are versus others, they themselves would not think that they're thin at all. So what might predispose somebody to developing anorexia nervosa? Well, we know that there's a strong genetic link within families, especially parents that have it, passing it along to their offspring. There might be some chemical imbalances, especially with serotonin or norepinephrine. So you might see antidepressants being used to help alleviate some of these symptoms associated with maybe their depressive symptoms or anxiety symptoms. There could be some changes in the size or the hyperactivation of certain structures of the brain, especially in those structures that deal with the feeling of satiety or feeling full after a meal. And in anorexia, this is an egosyntonic disorder, meaning that the person who has it highly values their disorder. They might put such a high value on being thin that they'll do whatever it takes to get there because they believe it's greater than the risks that are involved. They may be highly anxious or have perfectionistic tendencies to the point where, again, I've mentioned about being inflexible or having rigid thinking. There could also be some sociocultural aspects to this. The culture that they're in, do they value thinness in women? Are they raised in households where weight is always talked about? Or are they getting influences from social media, movies, images, and platforms that are pro-anorexia or glamorize anorexia? So what could we potentially see in our mental status assessment of someone with anorexia? These are just examples. It's a not inclusive list. So with their general appearance, they may appear very malnourished or cachectic. So thin, many of their bones are prominent, such as their rib cage or hip bones. And as a result of this undernourishment, their body compensates by growing fine little hairs called lanugo, usually on their back and arms, to also help regulate their body temperature as they can get cold very easily. Their hair and nails can be thin and brittle. They may bruise easily and have very dry skin. They may also have yellow skin as a response to the imbalance in some of the hormones and electrolytes in the body. For their mood, they may have underlying persistent feelings of depression, irritability, and anxiety around food-related thoughts and activities. Their thought process or thought content, they might have very obsessive thoughts about food, the calories in the food, their shape, and gaining weight. They may have, again, rigid thinking and cannot allow themselves to eat food that day because maybe they gained a pound. You might see some defense mechanisms such as black and white thinking, sometimes also known as all or nothing thinking. And it's like, I need to do this or this. There's nothing in between. And it's very hard to change their mind. It's a form of irrational thinking. Memory, attention, and concentration can be affected, especially under the conditions of starving the brain and the body of nutrients on a regular basis that's required for it to function. They may be easily distracted or have difficulty concentrating on a task, especially if they're ruminating about food or their weight. And this gives you a clue on how much this disorder might be consuming their life. And because of their egocentric characteristic, it can make it harder for them to see how damaging the effects are on their mental and physical health. Some behaviors to pay attention to are, of course, their eating patterns. How are they handling the food during meals? Are they cutting it up into small pieces, or are they just kind of moving it around? Are they maybe picking out certain ones? And if so, are those their safe food? These are foods that they've determined that it's okay to eat based on the conditions that they've given themselves. Often these safe foods offer little to no well-balanced nutritional value, might have high water content like cucumbers or watermelons, and having high water content can help them feel full a lot faster. They could also be very aware of the calories of certain foods. So maybe they're jotting these down, especially if they're trying to restrict to maybe certain calories. Some can be also very good at identifying calorie count of food because they've done their research. Assess their particular compensatory behaviors if they do use any. If you're on the inpatient unit, assessing their amount of movement versus food intake, documenting their intake and output will be helpful. Because there are obsessive thoughts that are associated with these eating disorders, it's likely that they may have compulsions, which are strong, irresistible, repetitive urges that are acted on to help alleviate any of the anxiety-like feelings that the obsessive thoughts bring. So, for example, they might obsess about feeling bloated from breakfast to the point it's causing them so much nervousness that they have to walk the hallways of the unit 20 times to feel right. How else does anorexia affect the body? Well, we talked about cardiovascular, how their blood pressure will eventually be low, so will their heart rate as the body tries to compensate for all that fluid loss. You might have maybe abnormal heart rate as a result of the electrolyte imbalance. Worst case scenario, they go into heart failure. They may be anemic. Their muscles and joints can eventually become weak, but could also be swollen. They may be prone to fractures and osteoporosis because they're not getting enough of those minerals in their body that is required. Kidneys over time, they can lead to kidney stones and, worst case scenario, kidney failure. Certain electrolytes are going to be affected, like potassium, magnesium, and sodium, which are big players in the cellular components of your body. Constipation. If you think about when your body is in a state of starvation, the digestive system will slow down and the body will redirect the energy to other areas that might need it more. In addition, most likely, these individuals lack adequate fluid intake and, of course, food. Bloating, they're not getting enough protein, so on a cellular level, it is messing up the pressures that allow that water to be retained. So the water gets pushed out underneath the skin. The body in this state also affects their hormone regulation and result in an absence of their menstrual period, bone loss, growth and development, and reproduction. Next, we're going to talk about bulimia nervosa. Bulimia nervosa is characterized by binge eating plus compensatory behaviors that occur at least once a week for 3 months. They eat a large amount of food in a designated period of time, like 1,000 calories in a 2-hour period. This would cause them afterwards to feel things like anxiety, shame, embarrassment, and as that builds up, they end up purging in any of the ways that we talked about before. These behaviors provide temporary relief until something triggers the cycle all over again. These individuals are very judgmental of their body shape and weight and have a distorted view of themselves despite looking normal or average size. What are some things that predispose or contribute to someone developing bulimia? So research has shown it does get passed on in families. Serotonin, norepinephrine, and dopamine are likely heightened, especially during the binge parts where it feels rewarding in the moment. There are some brain structures that have to do with the feeling of fullness, their connection to the emotions associated with the food or trauma, or if they have a distorted way of how they perceive their body. And all of that is playing into their mind. We might see distorted thinking like black and white thinking or the all or nothing thinking or overgeneralization. Could be that I eat all these cookies or I don't eat it. There's no gray area. It doesn't just occur with food, but it also could transfer to other aspects of their life. Moving on to the mental status assessment. So someone with bulimia, they might look normal as far as their appearance goes. They could also look like a little overweight, but not to the obese side. When you do a close physical exam, however, you could see enlarged parotid glands, and it could look like puffed up cheeks, and this is a result of the continuous vomiting. The vomiting can also cause dental erosion and dental caries. Russell sign, which are the calluses on their knuckles or behind their hand, could develop. You might even see peripheral edema because some of the nutrients that they are not getting in their body or holding onto in their body. They might express depressed or anxious mood, especially if you're trying to talk to them about or after a binge eating episode. They may engage in additional self-destructive behaviors. Some of these individuals could have very poor impulse control, and that could increase the likelihood of self-destructive behaviors from occurring. Their cognition and concentration is very similar to what we've seen with anorexia, where they may be distracted, they're not able to think straight, or again, if all they're thinking about is food or when's the next time they're going to binge and purge, that can affect their focus on, let's say, treatment or even the conversation. Assessing where they're at as far as their cognition goes also gives you a clue on their readiness to engage in treatment. For example, someone who might be ready to tackle their eating disorder might say something like, I'm so tired of going through the cycles, scheduling meetings, or doing this behind people's backs. I just want to be able to be free from this and be able to hang out with my friends and not have to worry about where's the nearest bathroom. We have to assess their patterns of binging and compensatory behaviors, how often they do it, what triggers a cycle, how do they feel during the cycle, and how did they feel after. They may also exhibit impulsive behaviors outside of the disorder, like shoplifting and substance use, that could also bring them back into a cycle. Like anorexia, compulsions also can present itself following their obsessive thoughts. Next, we're going to move on to binge eating disorder. And this is characterized by recurrent episodes of binge eating only. They'll consume a large amount of food in a certain period of time to the point of feeling uncomfortably full. For context, a large amount can be thousands of calories in one sitting. During the binge episodes, they may feel like they're out of control, and after the binge, they may feel shame or disgust or regret. The binge episodes usually occur at least once a week for 3 months and are dictated by the severity, how many episodes occur in a week. In between binge episodes, they may go on some kind of diet to regain control of their weight or go back to eating normal or exercising normally. They do not use compensatory restrictive behaviors, unlike what we've seen in anorexia and bulimia. It's usually something that triggers them that can feel the impulse to binge eat, and then comes the feelings afterwards. They could start off at a normal weight, but over time, they will be at risk for obesity, which would place them at risk for other medical conditions such as diabetes, hypertension, cardiovascular disease. Binge eating disorder is hereditary. Again, there is some kind of impairment in the way that they feel full after they've eaten. It's kind of gone haywire. They may be more impulsive and more sensitive to the reward system that the binge eating gives them. So in some ways, it's like when you find something that makes you feel content or satisfied in that moment, it provides a sense of relief for you, and that relief is short-lived. So it's reinforcing. So something in these individuals is setting off that reward system in this unhealthy way. They usually report that they just can't stop while they're binge eating and feel powerless to their disorder. Feeling dissatisfied with their body, having low self-esteem, or difficulty coping with feelings. Maybe growing up, they experienced emotional neglect and found food as a way to comfort them. Social pressure and stigma, feeling hopeless about themselves and feeling like it's too much for them to be a certain shape. So instead of restricting, they might turn to eating. Maybe they've had some kind of trauma with the way other people have looked at their body and end up eating and finding that, ooh, when I'm gaining weight like this, I no longer look attractive to these people. So that makes me feel good because now I don't have to worry about people looking at me in this certain way. So these deeply ingrained thoughts perpetuate the behaviors seen in this disorder. Food insecurities. Maybe they grew up or are currently living in communities where food is not easily accessible, or what is accessible are high-calorie, high-fat foods. Maybe they have to drive very far to get healthier foods. If they have access to food, they might eat as much as they can because they don't know when the next meal would be. So if they are growing up in this kind of environment, mentally this cycle could continue throughout their life. It almost becomes normal for them. There are also physiological and physical changes to the body, like delayed gastric emptying, enlarged stomach capacity, and decreased CCK, which helps the person feel satiated. And these factors can either predispose or contribute to the binge eating disorder that we currently see. So what does their mental status assessment look like? Depending on where the person is in their treatment, they may be of normal weight for their height or they may be obese. If they have been gaining weight up to that point of assessment, they could possibly hide their weight gain by wearing baggy clothes or multiple layers of clothing. Mood. They may have persistent feelings of depression, irritability, anger, or anxiety, but they could also experience additional or different emotions during and after a binge episode to which you'd want to assess. Thought process and thought content. Similar to anorexia and bulimia, they will have obsessive thoughts about food or food-related situations. There can be themes of shame, embarrassment, and disgust that exist after the binge episode, and they feel like they just can't stop, especially once the binge starts. Insight and judgment. Eating of food is a way of coping for them, but is a form of maladaptive coping. So to individualize this assessment, what does food bring to them? What does it give them? Some may feel a sense of comfort for triggering events, maybe a sense of control over things in their life that they don't have control over, or some sense of like rebelling against past trauma. Behaviors we should assess for, of course, their eating patterns. Are they eating more rapidly than normal? Are they feeling uncomfortably full after they eat? Do they eat even when they're not hungry? Are they eating alone because they want to hide how much they can consume in one sitting? Eating usually is a social activity. So how much of this disorder is contributing to their feelings of isolation? So what nursing diagnosis can we come up with for any of these eating disorders? Imbalanced nutrition, less than body requirements, applies to those with anorexia. Risk for overweight for those with binge eating disorder and possibly bulimia. decreased cardiac output, mostly for anorexia, but you can also probably see that in bulimia. Disturbed body image, that can go for all three, such as their negative view of their physical appearance. Risk for injury, now this is related to even some of those compensatory behaviors or restricted behaviors that is causing some physical injury to the body systems, and the tissues. Ineffective coping, mainly using food to cope with stressors, conflicts, and triggers. Chronic low self-esteem can apply to all three, judging their self-worth in a negative way. Social isolation, such as in the case with bulimia or binge eating disorder, trying to hide their eating behaviors, that can be isolating. Anxiety, a strong emotion that usually kickstarts the compulsions of the eating disorder cycle. Or maybe they have very high anxiety about how they plan for food or plan to eat their food, or what kind of food to eat, or just constantly thinking about it. So planning and implementation. What are we going to do? If we consider Maslow's hierarchy of needs, we know that their basic needs must be addressed first, which includes their physiological and psychological safety. For those with eating disorders, this could mean addressing critical labs and immediate complications. Refeeding syndrome is a potential complication in those with anorexia and possibly bulimia if their nutrients are replaced too fast. We have to slowly integrate nutrition back into their diet, usually taking about a week. At the same time, we have to address any acute psychiatric symptoms. For example, self-harm or self-injurious behaviors that accommodate some of these disorders. Those with bulimia or anorexia, you may need to supervise them a certain amount of time after each meal or feeding to ensure they don't purge. Observe and monitor their movement or physical activity. What are they doing before, during, and after eating? Are they pushing their food around, consuming a certain amount of food, or not eating certain foods? And then after their meals too, are they going to the bathroom after every meal? How long are they staying in the bathroom? Are they asking for laxatives or diuretics to be ordered, or if those are PRNs, are they taking it on a regular basis, almost as if it was scheduled? Monitor their intake and output and inquire about it in a matter-of-fact way. Those with anorexia, you may need to weigh the client daily after the first void of the day, before their first meal, and in only their underwear or hospital gown, depending on the unit's policy. They should also have their back turned towards the scale to prevent them from perseverating on their weight. And once these symptoms have been stabilized, especially their medical needs, you and the patient can start developing goals towards their recovery. You have to get a good sense of what's important to the patient and consider including that in their plan. If you make it unrealistic or unattainable for them, it could be a source of frustration and discouragement that they might throw in the towel or feel like the plan is not working or they're not working hard enough. Remember, many of them grapple with low self-esteem, and by working with them on the goals that are doable for them, it can boost their self-esteem once they've achieved it. Some people may be particular about certain words that either trigger them or they don't like to refer to a certain name because of the stigma. So it's also good to understand what's their own personal vocabulary on how they would describe it. Let's say they have a certain word for their binge eating purging cycle or their compensatory behaviors. So when they share that with you, I think it's good to also consider using that in your conversations with them. If the patient is ready to address the physical aspects of their eating disorder, nutrition and weight restoration can be considered. Most likely you'll have to refer them to a dietitian who can work with the patient to create a meal plan to restore them to an ideal body weight, shape, and height. And as their nurse, you'll likely carry this out and provide assessment and evaluation of the plan. For some, aspects of their treatment and interventions can lend itself to the person feeling a loss of control over their eating patterns. And sometimes losing this control can make the person seem like they're being defiant or oppositional or acting out, all these labels. Empathy and acknowledgement for their experience can help the person feel heard and validated. How do we give back a sense of control while working with them towards their goal? Under the assumption that this plan was worked in tandem with the patient and their family, if applicable, everyone needs to be on the same page on what the goals and interventions are. Maybe if they're at the beginning of their treatment journey, structuring conditions will need to be established, such as limiting mealtime or scheduling an activity right after meals. And as they show progress, you can expand their choices and interventions. Focus on the emotions precipitating behaviors. In these disorders, food is usually a symbolism or outlet for something deeper. Developing an understanding of what sets off a cycle or episode. Explore with the patient how they feel after an eating or compensatory episode. This is also the first step before discussing healthier coping techniques. If you can help them become aware of the feelings that may trigger purging, future purging may be avoided, for example. Health teaching and promotion. So in addition to the patient, don't forget to involve their loved ones, with consent if the patient is an adult, of course. They may need education too about their loved one's eating disorder and how they can help support them. Education about the disease process, the complications that can happen from being untreated, the pathophysiology of the body in well-nourished versus malnourished states could make a difference in their treatment, especially with a lot of false information out there. It could also be that maybe they're not open to hearing it now, but down the road, they could remember what you said and maybe it's just going to click one day for them. Collaboration and teamwork. Who else from the interdisciplinary team could you collaborate with to help develop this treatment plan with the patient? Treatment modalities. Behavior modification can be used to reinforce positive behaviors and also establish consequences for negative behaviors with the sole aim of restoring weight. So establishing maybe a behavioral contract in collaboration with the patient that outlines desired goals and interventions. Cognitive behavioral therapy and dialectical behavioral therapy are evidence-based treatments that help the patient reframe their negative or irrational thoughts to influence behavior changes. The Maudsley approach is a treatment helpful for adolescents with anorexia nervosa and is done in collaboration with the client and the family. It has 3 phases: weight restoration, weight maintenance, and developing a healthy self-identity. Each phase builds on the client's locus of control, such that what is within their control versus what is outside of their control relative to their weight gain. Individual therapies help address underlying issues that could be playing a role in the behaviors seen in their disorder. Developing this perspective can be a stepping stone into finding adaptive ways to cope with triggers and stressors. Individual therapy is usually more effective when it is used with other forms of therapies and not just by itself. Integrative therapies or alternative therapies like yoga and meditation can help the individual be more in tune with their mind and body and build that connection. It could help with practicing anxiety-reducing techniques like deep belly breathing and grounding. And medications. Medications work best in these individuals when combined with the other therapies just mentioned. Anorexia, there's none that have been identified to treat the core symptoms, but they can be prescribed medications to treat associated symptoms like depression and anxiety. Bulimia nervosa, antidepressants from the SSRIs, TCAs, and MAOIs have been effective treatments and are listed here. Fluoxetine is currently the only FDA approved. They help increase serotonin to improve mood and anxiety and helps in the reduction of symptoms. And for binge eating disorder, SSRIs at the higher doses have been effective for weight loss, but it's only short term. Once these medications are stopped, the person will eventually put the weight back on. The anticonvulsant or mood stabilizer topiramate and the CNS stimulant lisdexamfetamine have shown to reduce binge eating and weight gain in moderate to severe cases of binge eating disorder. They have an effect on weight loss or appetite suppression. Treatment modalities.